So you need to have this type of bone meal, which has a stopper. I cannot use my cursor today because it's a webinar, but there is a stopper on this bone meal to control what the particle size you can make, and so that it's very convenient uh, in terms of determining the particle size. Now I will place large healing abutment. In this case, I chose to use 8mm healing abutment, and you will have about 1 or 2mm gap buccolingually, but that's not a problem because if you give multiple sutures like this to give some compression, you will block that gap without any problem. Okay. 3 months later, it looks like this. One mistake I made here is I forgot to give the patient a retainer, because always second molar will try to mesialize. So here you can see a little bit of mesialization. I had to do a little enamelplasty on the second molar because of second molar tipping. I will remove this abutment, and then we have a very healthy tissue around implant. I will place this stock abutment, and I just take direct impression and send the abutment with the impression, so that my technician, great technician, he can make a nice coping for me, as you can see here. Now, I like, one of the disadvantages of stock abutment is that it's round. When you have a round surface coming up to a relatively square tooth, you cannot have a nice line angle, and that's where the foot gets stuck and patients have discomfort. By having this type of square coping, you have a much better emergence profile for the patient, and you have a less likely to have a foot getting between the black triangle. And not only that, I don't like to make a screw type because patients hate the cosmetic of the occlusal surface. By doing this, I could have a lingual slit where it's filled in with cement, as you can see. And if I need to remove it for any reason, such as porcelain fracture or screw loosening, I can pop out this crown from this lingual slot that I made. So it's a cementable, but it's also retrievable. If you guys want to find out how to make this, you can contact my lab technician called Mr. Chung from Megasys Dental Lab. Great guy, very fair price. I want to give out his phone number, 714-502-0900. His website is megasysusa.com, megasysusa.com. So you could ask him how to make this coping. But as you can see on the lower right, it has a nice emergence profile. It looks like a natural tooth. It doesn't look like a implant crown, because it has a very nice square coping under the stock abutment. And I could assure you this is going to cost half the price of UCLA abutment. Okay, so it's better for your clinic too, because it's very economical and very nice way to do beautiful restoration. So I recommend you to do this. How about mandibular? Mandibular, here we have a failing tooth. Patient came in with a fractured crown. And mandibular, same thing, you do atraumatic extraction by sectioning the tooth. But here on the mandibular, you have to remember not to go right onto the furcation, but go a little bit slightly to the mesial. That is very important on the mandibular, because always, due to curve of speed, there is a slight tilt of second molar mesially. And if you go right onto the furcation, your implant looks too distal. And I will show you at the final X-ray what I mean by that. So position like this is very nicely done, a little bit more mesial from the furcation. And same thing, I will put healing cap, pack the bone, put large healing abutment. My favorite size is 803, which means 8 millimeter diameter and 3 millimeter height. And then I will give some suture. This is I don't remember, but I think it's 4 or 6 months later. You can see nice bone preservation around implant. In this case, on the distal portion where there's no implant, you could see some resorption of buccal plate. So it's always good to place implant. In my opinion, well, does putting an implant right after extraction preserve the buccal plate? It's kind of yes and no. I mean, if you look at Dr. Linde's literature, it shows that it does not preserve buccal plate. But in my opinion, it really depends on the scenario. If patient has a very wide basal bone, it will preserve buccal plate. Almost always, it will preserve the buccal plate on the second molar region. Why? Because on the second molar, there is buccal shelf. And because of buccal shelf, I never seen resorption of buccal plate after placing implant. On the upper first and second molar, always safe to place implant right after. However, the biggest problem is lower mandibular first molar area. In very thin gingival bone, gingival biotype, very narrow basal bone, you will see resorption of buccal plate. Therefore, I recommend you to leave at least 3 millimeter of buccal bone to prevent resorption and placing some slow resorpting bone on the buccal plate. In this case, I made a small hole on the occlusal surface for 2 reasons. Number 1, to let the cement escape. Number 2, if I have to retrieve it, I know where the screw access hole is. So, rescue implant is another a good tool that I use in my clinic. Whenever I have a failing molar, I will extract and place this rescue implant. I think this is 6.5 by 8.5 millimeter. As you can see, this is far away from inferior alveolar nerve. Typically, from CEJ to the apex of the tooth, it's about 11.5 millimeter. And if you place 8.5 millimeter implant, it's a lot shorter than the apex of the root that you extracted. Therefore, without any fear, you can place this implant. And buccolingually too, you have more than enough space to place this implant. How about if you have an infection around apex of the tooth? Here, a patient presented, she's dentophobic, and she had a pain on number 15 every time she bites down. I mean, she needs a lot of dental work, as you can see. She needs a lot of crowns, some implants on tooth number 3 as well, some open margin, crown, and fillings, and so on. But she said, I want you to fix only number 15. And if implant is painful, I don't want to do it. So I told her, well, if I extract and do nothing, it's going to be more painful. Why? Because you have a bone exposed to oral cavity. But if I extract and put an implant right after, that's going to block the bone from oral cavity. Therefore, you're going to have less pain. So, as you can see, she has chronic lesion here, periapical lesion, but it's not connected to the sinus because sinus membrane is not thick. You have to do atraumatic extraction, and I will extract. I will ask the tooth, where do you want to come out? And this tooth wanted to come out buccally. Asian people are very easy to extract because we have a very small face. Short root is very easy. But African American or very tall Caucasian is not this easy, right? So here I have a granulation of tissue. I will use any tooth drill that I don't use in 2mm or 3mm in diameter, and I will go into every corner to remove this granulation of tissue. If you use the spoon to do this, by the time you finish degranulating, you feel so tired. Your hand is so tired, you have no strength to place an implant. So if you use the motor at 200 RPM, it's not fast enough to cut the bone, but it's fast enough to remove the granulation tissue. So I'm removing granulation of tissue. I want to remove 200% of granulation of tissue. I don't even want to leave 1% of granulation of tissue because they grow a lot faster than your bone graft. And then I will use trephine. I'm using 6mm trephine at slow speed because I have much more time to check my angulation. And I don't have to use water so that patients have better comfort. I call this waterless technique because I'm not using any saline. So using waterless technique, I have more time, plus patients feel more comfort because they don't feel like they're drowning. After I go 1mm longer than my depth, I will insert this implant. This implant is great because delivery unit has a millimeter marking. So you know how deep you are in relation to the margin of the gun. Let's pretend that buccal margin of the gun is 3mm from the buccal bone. I want to place this implant 1mm subcrestally from the buccal plate, which means I want to place this implant 4mm from the margin of buccal gun. So it allows me to know height of my implant without opening flat. And then I will place healing cap. With the bone that I collected from the trephine, I will take it and pack around my my implant that has a gap. But you don't need to pack this bone all the way to the apex. My goal is to use this as a barrier to retain blood clots, because if there is blood, I believe that there will be bone. So I just pack around the gap on the coronal portion. After removing the healing cap, I will place large healing abutment. And then we have a primary closure. Instead of doing sashimi, I think this is way better way to get primary closure. So patient told me, "Wow, doctor, you're right. I did not have any pain. Can you do implant number 3? Well, I told her, "I'm sorry, I cannot do implant number 3. Why? You did implant number 15, why not number 3? Because number 3, I do not have the right amount of space. Whenever you lose a tooth, there is a migration of adjacent teeth, and even the opposing tooth will super erupt. So I told her, without braces, I cannot do it. So here, she decided to do full mouth braces. And I truly believe that every implant case is also an orthodontic case. So here, I will make a space. As you can see, when I have a 7.5 millimeter space, that's the magic number. I will place my implant, because when I have a 7.5 millimeter space, I can place 5 millimeter implant, and then I will continue to distalize. This way, I will save patients time. Let me show you how it looks like 6 months later. Here I took out the healing cap. We have a healthy tissue. I put the stock abutment, and then we will restore. But what if the socket is too large and you cannot place 10 millimeter healing abutment? Then you can do this semi-lunar coronally place flap to close. For example, here implant is placed slightly more buccally, and patient's tooth have has a huge gap on the palatal side. Here you can do little smile design to bring it up. I will use anchoring suture to bring up the palatal tissue, and now you can have primary closure. Also, you can use collar tie technique where you take a collagen and you kind of wrap it around like a necktie, and then you put it around the healing abutment, and then you squeeze that in. But collagen, if it's wet, it will shrink a lot. So here, it looks like it's too big, but it's actually not, because you can really pack that collagen in and get primary closure like this. So this is another way to get primary closure when you have a too large of a socket. Okay, here I did some internal lift, and if you want to learn about internal lift, I think there is the video on Dental XP for you to listen to it. So here, as you can see, after 2 internal lift and the immediate molar placement, we took out the healing abutment and we made a nice restoration for the patient. And that hole will be filled in with the glass ionomer Fuji Plus. And here, as you can see, we lifted the sinus just a few millimeters and restored the case right after the extraction. How about when you have a poor initial stability? Now you cannot put healing abutment. Well, I think the most smart way is to place larger implant. So if your 7.0 implant is a spinner, put 7.5 millimeter implant. Now you will gain good initial stability. Well, if you don't have the implant stock, or if you don't have the available buccal bone, then I recommend you to get primary closure as I showed you and submerge the implant with the healing abutment. Or you can use open membrane technique with non-resorbable membrane. But my favorite way to close this is using PRF as a membrane. And let me show you how to do this. So as I showed you, you can get primary closure by doing buccal releasing and the palatal releasing, but you are losing amount of attached gingiva. So I do not like this way. What I like is PRF. Here I have a poor initial stability. It's a spinner. I will use FDB, freeze dry bone, oral graft from Salvin Dental. And then also Salvin Dental has this great centrifuge and a test tube that they sell. And I will just spin it down, but you must not have any preservative. Salvin Dental has 3 different types of test tube: blue color, yellow color, and a red color. Red color does not have any preservative. I recommend you to use that, because the yellow color or blue color with the preservative is actually for PRP technique, because you don't want that. You don't want the blood to clog it up. But when you want to do a PRF with the fibrin, platelet-rich fibrin, then you want to use without preservative so that you can make a membrane. After spinning for 15 minutes, now you have a biological membrane, as you can see here. And I will put that as a membrane, and then I will give multiple suture like this. And then Salvin has this great periacryl, which is crazy glue, which you can put it on top. And 1 week later, patient comes back like this, beautifully healed. And then you have a nice healing after 1 month. So here I will do a little tissue punch with my number 4 round burr with the handpiece, and then put healing abutment, and then restore the case. Okay, so even with my sinus technique, combined with this immediate molar placement technique, now sky is the limit. Here, after extraction, I did internal sinus lift, and remember that my crestal window technique is the only technique that is crestal approach and is not a blind technique. So it's a very powerful technique, because this is not, as you can see, is not applying technique. I put healing abutment to get primary closure, and then I can restore this case in 6 months. Typically in this case, if you don't have these tools in your toolbox, you have to let it heal and then do sinus augmentation. If you do two-stage approach, you place implant 6 months later, and then you restore. The treatment time will take longer than 1.5 years. But if you do it this technique where you place implant right after extraction and you do sinus lift through socket, you can finish it from start to the end in 6 months. So you benefit and the patients benefit from this service. I would like to conclude my presentation. I hope that you enjoyed this presentation. If you want to find out more about my seminars, we offer great seminars. You could log into firstchoicedentalgroup.com/seminars, seminar singular, and we have a lot of live surgical demonstration which is done in my office. So you could, if you want to come to Disneyland in California, my office is about 5 minutes away, and you could send your kids to Disneyland and you can enjoy observing my surgeries in my office. So please check out firstchoicedentalgroup.com/seminar. Thank you very much for listening to it, and I hope to see you again. Now I will take questions. Thank you.